Hi, I'm Stephen Russell. Today I'd like to show you the exam that can be used in a 10-minute moment for shoulder pain. This demonstration of the shoulder exam is one example of how the physical exam of the shoulder can provide real-time information for next steps in management. The 10-minute moments from the Society of Bedside Medicine help assess the physical exam skills of trainees. Each 10-minute moment contains two parts, a faculty development section and an assessment section. Keep in mind, the 10-minute moment is a tool used to assess physical exam skills alone. It is not designed to assess history-taking skills. Before performing the shoulder exam, the examiner should have a sense of how the exam will help determine diagnosis and management. Patients younger than 40 years old are more likely to have tendinitis of the shoulder muscles, while patients older than 60 are more likely to have a tear. After cleaning your hands, the first step of the shoulder exam is to observe the uncovered shoulders. Check anteriorly and posteriorly. Be sure to notice any scars or skin changes, paying special attention to the affected side. Also note the muscle tone and muscle bulk of the shoulder and the surrounding structures. Often patients will have subtle muscle enlargement on the side of their dominant hand. Noticing muscle atrophy on the affected side can also yield clues to the diagnosis. Muscle atrophy on the affected side speaks to a more chronic process. Pay special attention to the supraspinatus muscle, as this is commonly a site of shoulder pathology. Having a structured and systematic approach to the palpation helps confirm you've evaluated the entire shoulder. Now, having just completed the observation of the posterior shoulders, palpate, I'm going to feel right here, palpate the cervical spine, the muscle body of the trapezius, the supraspinatus muscle, the infraspinatus muscle, and the quadrilateral space. Note any muscle spasm or muscle tenderness in these areas. Make sure you also palpate the area of concern. You may need to examine the contralateral side to compare and confirm your findings. Examining around to the front of the patient, palpate the subacromial bursa laterally, the clavicle, the coracoid process, the AC joint, and end with the insertion of the bicipital head. Now, typically I'll do this in front of the patient, but for demonstration purposes here, I'm pointing out the structures. You're checking for point tenderness or instability in these areas. Now that the observation and palpation is complete, it's time to check for range of motion and provocative maneuvers, which will help with understanding if restricted movement or impingement is present. These can often be assessed at the same time and typically bilaterally, which can help compare the strength between the sides. First, have the patients extend their elbows out and abduct their arms with their thumbs down. Can you do that for me? As if they're emptying a canned drink beside them. This fully activates the supraspinatus. Your first assessment is to determine if they can hold their arms against gravity in this position. Next, place one of your hands on each arm and have the patient resist your downward pressure. You're testing for pain and weakness of the supraspinatus muscle with this maneuver. Keep in mind, if you've already identified supraspinatus atrophy, the patient may not be able to hold their arms against gravity on their own power. You can go ahead and put them down. Next, use the exam to check for impingement or compression of the tendon between the shoulder structures. There are several tests that can be used to elicit this information. The Neer's impingement test is an example of one of these. With your hand placed against the ipsilateral scapula to stabilize it, have the patient internally rotate the shoulder by placing the back of their hand against their side, thumb back. This turns the humeral head, closing in the subacromial space. Once positioned, lift the patient's extended arm 180 degrees to be above the head. This brings the elbow near the ear, and if tenderness is elicited in the subacromial space, this is a positive Neer's test for impingement. Another test for eliciting impingement is the Hawkins test. The principle is the same in that the examiner tries to progressively narrow the subacromial space. The patient will likely experience pain if the narrowed space presses on an inflamed tendon. The examiner abducts the patient's arm with the elbow bent at 90 degrees. While supporting the arm, the examiner drops the ipsilateral hand internally, rotating the shoulder joint. Maintaining this position, the examiner progressively adducts the extended arm and repeatedly internally rotates the affected side, narrowing that space, stopping when pain is elicited or the arm is fully adducted. One can imagine the hand of the hawk as a wing of a hawk, flapping across the chest in search of signs of impingement. This is the Hawkins test. The final part of the examination is to assess the infraspinatus muscle. The infraspinatus muscle is located, of course, inferior to the spine of the scapula. The muscle is used to externally rotate the humeral head. Imagine opening the morning newspaper. This movement has the elbows anchored at the side and the hands drifting away from the midline because the infraspinatus is contracting and externally rotating the humeral head. We test this clinically by mimicking those movements. Have the patient press her elbows by the side as if pinned in the middle of an airplane seat. With the thumbs up, provide pressure on the dorsal surface, resist me if you can, to try and measure the strength from one side to the next. A positive test for infraspinatus weakness is found when the examiner notices a difference in power from one side to the next. A more subtle finding is noted when the examiner releases pressure on the hands. The affected side, which is unable to maintain the contraction of the infraspinatus, the hand subtly drifts towards midline. One final test that can be done is the Shaw test, which tests for AC joint tenderness. Simply have the patient take her hand and cross it around her shoulder. While doing so, if pain is elicited in the AC joint, that can be more information that can help you assess a painful shoulder. So now that we've inspected the uncovered shoulder, palpated the major structures, and performed strength testing and impingement testing, how do we interpret these results? It turns out that none of the tests individually give us the answer we're seeking, but collectively, these tests can have excellent predictive power. If your pretest probability for rotator cuff tear is high, based on the patient's age and chief complaint, then supraspinatus weakness, signs of impingement, and infraspinatus weakness dramatically increase the likelihood of a torn rotator cuff muscle. Alternatively, if your pretest probability for a muscle tear is low, also based on the patient's age and history, then the collective absence of physical findings with these tests can help guide next steps in management. In the case of a normal exam and a low suspicion for a tear, your patient is much more likely to benefit from conservative measures, such as being scheduled with a physical therapist, rather than additional workup with advanced imaging. For more information about the techniques demonstrated in this video and the interpretation of the findings, visit bedsidemedicine.org.